Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Well, I will do a quick. We're here with Jake Potter from Scope Medical Education. Thanks for coming back, Jake.
Yeah, absolutely. Thanks for having me, Mike.
And Josh Cooke from the Alert Medic One podcast, who you all know. Welcome back, Josh. And we have no agenda. This is. I think Jake has a couple things he wants to talk about. I have one or two things I want to bring up, but we have no agenda. So we're just going to shoot in the dark and record this. So what do you guys got?
Josh, do you have anything first?
You can lead it off, man. Go ahead.
All right. So I had an interesting thing I wanted to chat about.
We'll be the judge of whether it's interesting or not.
I wanted to do like a thought exercise kind of thing. Going by therapy session. No. I want to do a build your medical director chat. Basically build our perfect medical director.
Okay.
And I'm hoping it won't piss off any medical directors, but whatever. No, I think it's an interesting thing to talk about because obviously we all have medical directors.
Okay.
Here, I'll wait till he gets back on.
Type of connection issue with somebody. Dun, 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 dun. Oops.
I love the UNC Air Care patch behind you.
Yeah, they've been following the podcast for pretty much since the beginning and sent me some stuff.
They've got a really good social media presence.
Yeah, they do. Okay, so Jake, shoot that again. What's this thought exercise you want to do, people? We had some technical difficulties and Josh is back.
Yeah. I wanted to do like a thought exercise for like build your medical director, build your perfect medical director. Because we all obviously have medical directors, but some are great, some are not so great. And I thought it'd be interesting to see what you guys, because obviously you have different medical directors than I do, and we've all had varying degrees of whether it's very part-time that essentially just sign paperwork and never are seen unless I'm in the ED. And then I have, like where I'm at right now, we have 3 full-time medical directors who are dedicated to us. And so like I wanted to see what everyone thought about what you guys look for in a medical director.
They don't come from Beth Israel Deaconess Medical Center in Boston.
That's a good start.
Very specific, Mike.
I wonder why. I'll lead it off. So I think if I could boil it down, let me think. I'm going to boil it down to 3 main things. Number 1 is be open and communicative with your field provider. So like be someone that is able to be talked to at essentially the kitchen table and have an open conversation and don't be shut off. Like listen to what your field providers want and also give good information other than, well, I just don't like that back on ideas that they present to you. Number, I'll say 2 is someone that comes out in the field, like not just talks at the kitchen table, but maybe shows up on calls, is an active part of the process. And, they don't have to show up on everything, but be available, run calls, be there. And number 3, be progressive in the right way. Don't always look at the EBM or evidence-based medicine and go like, knee-jerk reaction, we're going with that. But also don't look at it and be like, well, I don't like that, so I'm going to hold back. Like find that like nice middle ground and move forward without becoming stagnant. I feel like that's what everyone would want overall. Mike probably is going I have a feeling he's going to share a lot of the same opinions on that, but that's where I would go. I've had medical directors of both types, of all types. I've had ones that show up on calls, that come to the station and have conversations, and I also have ones that don't. They just don't have conversations with the field. And yeah, you got to find that nice middle ground without being too involved in the field, but not too involved in the office. So
yeah, no, I completely agree with all that. That's actually some of the stuff I had written down. One of the things I had was accountability and transparency. It's kind of the same with you, is like, if they mess up, or if they give you an order or deny you an order for something that they should have, not denied you for, maybe be like, hey, that's my bad. I've had times where I've asked for something and they said no immediately, and then they call me back later after the call, of course, but they're like, hey, I said no without kind of talking to you more first, and I apologize for that. And they have like a discussion with me afterwards, which is really nice. But just someone like you said that's open, that will actually have a chat with you about, hey, this is why we don't do this, this is why we don't do that, or this is why I'm looking into doing this. And one of the things my medical directors do that's I really like is they present the evidence in CME. So like when we implemented TXA, they brought all the research and all the data, and they actually broke down like the statistics of it and made all of us aware of it. So it wasn't just, oh, we're implementing this, this is why, and you're just going to give it.
Yeah. I think it's also worth mentioning that the three of us come from very different systems. And I'm not just talking about how like we literally like go to calls and what our, daily life at work is, but how medical directors work. So in Maryland, when I call for orders, I'm not talking to a medical director. I'm not talking to someone that is assigned a role as listening to the box and being at medical command or whatever it is. I'm just talking to a ER physician. And that's because in the state of Maryland, our medical directors, they're mainly, I'd say, in an admin position within the systems. They're not in the field. They're not actively taking phone calls, radio calls, or even field calls for the most part. They may do time in an ER that is in their system just because that's who they work for on the side. But it's very different. I know with Mike, they call medical command, and that is a doc that is assigned to that position and is going to give orders. And they, I imagine have a state protocol book or something, right, Mike? And
no, we have random ER doctor of the day.
Okay.
Pick up
there you go.
The phone. It could be an amazing medical director who was a paramedic before, or it could be some idiot who has no freaking idea what the capabilities of EMS are. And you say, hey, can I have orders to give, I don't know, just say, can I have orders for ketamine for pain management? Not that we have to call for that. And they'll go, oh, I didn't know you could do that. I don't think you guys should be able to do that. No. Yeah, it is doc of the day in Pennsylvania. Sorry.
That's essentially what it is in Maryland too. Like it's whoever is available to get to the box when we ask for a physician for orders. And that's it. Luckily in Maryland, we don't have to call for a whole lot, honestly.
Yeah, and it's very different. Yeah, we're kind of the same. We don't have to call for orders for a lot. Usually it's like wild things or just kind of things you don't really think about. For us, specifically where I am, we have 3 full-time medical directors, like I said, and then we usually have 2 fellows. And so when we call medical control, we're calling our docs. The only time we talk to the hospital is like, I can't get a hold of any of my doctors and I need orders for something. Like I've maxed out my Versed and we have a status seizure patient. That's about the only time that we're talking to the hospital themselves. Usually we're talking to our docs, which is kind of nice because they know us for the most part. But
so yeah, that's just something I think is worth mentioning. That's different in how we build our medical director too. So Mike,
what do I think? I think you guys brought up excellent points. And I'm not just trying to kiss your ass, Josh. I like that you brought up that you have medical directors who are both progressive and judicious, because I have talked to places or people from systems in places like Texas where their medical directors credential them to do procedures and
just do a thoracotomy while you're at it.
Yeah, I hear stuff like that. And I'm like, on what freaking planet did this doctor think that it's not that it's okay for paramedics to do it? Because I think you can train people to do pretty much any procedure, but let's take like a field C-section, for example. One, I don't know of any ER physician that's going to feel confident doing that, period, let alone training, credentialing, and then resting your medical license on paramedics practicing under your license to perform that procedure. It just, I don't know. I do hear of some of these medical directors that are too like, oh yeah, you guys want to do that? Do that. You want to drill into someone's head with an IO gun? Sure, I'll credential you to do that. So I do think that medical directors have to practice a little bit of restraint, but that isn't the norm. Usually, from my experience, you're dealing with medical directors who are uninterested in EMS. They're collecting a paycheck and they sign off on the yearly form saying that, yep, you've met all the education requirements. I have watched you practice and you can practice under my service. And they stamp your form and you never see that doctor again. They don't know who you are. In Pennsylvania, there's a county medical director. I've been there for 12 years now. I would not know this man if I laid eyes on him. In fact, I'm not even sure of his name, to be honest with you. If you said it, I would say, oh yeah, that's him. I'm not sure what a county medical director does. I know he's the highest paid county employee, but he's pretty uninvolved and doesn't really do much. So that is a problem.
Yeah, something that our medical director does to kind of address that whole part of like, I don't even know who they are or they don't know who we are. And he even acknowledges it. Like he's self-aware enough that he's like, I can't, in our system, I can't literally lay eyes on everyone every year when it comes to research.
That is much different. Somebody's got an echo. That is much different from I'm just so uninvolved and I collect a paycheck. Yeah, if you're the Philly Fire medical director, there's no way you're going to get to know every paramedic and see them practice.
Yeah, and so what he does is when we do our credentialing, he straight up says, he's like, look, I cannot see you guys every year, and this is my time to give my stamp of approval on you for basically the rest of the time that you're a paramedic working in this system. The only time I'm probably going to see you is if there's an issue, and hopefully I don't see you. So he like has candidates write a bio about themselves and see where they're from, what their aspirations are and stuff. And he holds on to them. Like ever since we started this credentialing process that we did, and that started in 2016, he keeps all the bios. So like, he has a running idea of who people are. And then there's some of us that like work a lot with him or in other realms, and he knows us by, face and name pretty well, but he's got 400 something medics that work underneath him. And that's another thing in Maryland, we don't work under him. He is the person that says we're allowed to work in the county essentially, and then decides what the county is going to do within the overall state protocols. Maryland, we're all individually licensed as paramedics, whereas in Texas it's delegated practice, so it actually is underneath the medical director's license. So another difference in medical direction.
Yeah, it's the same in North Carolina. I have to have, like, I can't go into the next county and practice ALS unless their medical director signs off, which is the same in New York as well. Because that's where I'm from originally, but there's a lot of states that are like that, I think.
You know what else I think is an underappreciated aspect of medical direction that I've come to appreciate since getting to know our state medical director is the ability to understand and work your way through the state politics or the local politics, and being able to communicate that. So we focus a lot on all the clinical stuff, which we should, and we should hold our medical directors accountable for allowing good clinical practice, good QA, things like that. But it's easy for us to sit around and bitch and be like, why don't we have RSI? Or like, why aren't we doing DSI? And the next state over is doing this. Our medical director is really masterful at not giving any information past what he's allowed to, but he's very good at communicating like, hey, there is a political process here. I cannot just show up like a bull in a china shop and wave my medical director magic wand. So it's understanding that process, knowing how to game it, and then being able to communicate that to the paramedics and EMTs out there and be like, hey, I hear you. I understand. I'm working on it. But here are some barriers that I have at my level that I need to get through.
Yeah, I agree. Like, I always tell people, and my mind has changed multiple times on this as I've learned more. Like, I'm not a doc. I'm not a medical director. I don't know exactly what they do on a day-to-day basis and what they deal with. Like, I've had conversations with people who are like, well, why are they doing this? I'm like, well, do you understand that, you and I are very different medics than everyone else. They QA people's charts and they see some of the things that are done in the field and they're like, I don't know what they were thinking. Not that we should be writing for the lowest common denominator, because I hate that, but I do understand from a medical director perspective why they do it like that.
Yeah, I mean, it's liability. There are liability constraints. In a perfect world, yes, you would be practicing the Jocko Willink philosophy of, oh no, like, no, you can't set a low bar. You put the bar up here and you bring everyone else to it. If you're in an agency of 400 people, like Josh said, at some point there is a minimum standard that you need to establish. You can't raise absolutely everybody up.
And that's why
right.
Yeah, I was gonna say that's why I'm a big fan of like the systems that do kind of a tier. Like you're in a tiered system, I'm in a tiered system. That's not what I'm talking about, but I'm talking about like tiers of paramedic, like different levels of provider. So like you have your standard field medics, and then you have your critical care paramedics, or like different levels, and then your scope of practice escalates based on that. And I think that's a really good thing, because it still has that liability of like not everyone's going to perform RSI, but hey, these specific cadre of medics who I've trained, I've overseen, and I know that they're going to do the right thing, but they're also going to be held to a higher standard and more accountable. Yeah, I think that's an interesting topic of discussion in general in EMS.
Yes. What say you, Josh? Josh is in power save mode, apparently.
Sorry, you cut out for a second. It's funny you bring up that higher level, that critical care, that APP, good old paramedic practitioner word, just to get under Mike's skin just a little bit with that word, or two words. But yeah, I think we're going to start seeing that coming to fruition, though, in more systems. I know, Jake, your system has something like that. It is and it isn't at the same time, I understand. There are other systems that have it. It's way more predominant in Texas because of how they do their practice. But we are starting to see that there are people that should be pushed. No, I'm not saying should be pushed, are pushing themselves and should be given the ability to perform higher in the field, because we're finding more and more. And I've said this a couple of times lately. I don't know why. It's just coincidental in the past month or so I've said this, but we are literally bringing the ER to the side of the patient. Gone are the days of throw them on the stretcher, throw them in the back of the unit, and diesel therapy, to be quite honest, in most of America, I'd say. I mean, I know there's places that probably still have protocols that are somewhat similar to that logic, but, we're bringing the majority of the ER's care to the bedside in the house, I'd say. I mean, yeah, we're not doing sutures. Obviously, we'll never have portable x-ray. If you've ever seen a portable x-ray machine, it's still not portable. And, there's certain things that we'll never be able to bring, I think. But even then, sutures, that's being done.
We do have mobile
people.
CT scanners, though.
That
don't get me started.
More words to get under Mike's skin. Right now, his skin is just getting raised and raised. He's going to break out in hives here in a moment. Just wait, just watch. So we're bringing more and more. So why not be able to have certain people that do bring even higher level stuff to the bedside when they're showing that they have the ability, the knowledge,
it's interesting
and
you
the
say
drive.
that because I've seen in the UK, for instance, in London, they have what's called advanced paramedic practitioners. I know Mike hates those words, but they are essentially like a PA level, and they respond to only the highest acuity incidents, like the cardiac arrests and the major traumas. And they're not physicians like they have London HEMS, but they're within London Ambulance Service. But they also have they have the APPs in critical care, which are what we would think of like they're doing the RSIs, they have vents, all those things. But then they also have APPs in urgent care, which is more of the community paramedicine side. And it's like, oh, we can, they can prescribe meds, they can go do sutures, they can do all those things, which kind of goes into the paramedic practitioner realm that we talked about. But I think it's a very interesting like setup that they have over there.
So it's something that in my system we're starting to talk about, and it's going to take a little bit to roll it out. But right now, our supervisors are bringing blood, POCUS, vents, and those are the big three things that they're bringing to the patient side that we don't have on every unit. But we're like, how about we separate that clinical stuff from the supervisor and let them do supervisor stuff, admin, manage the hospitals, manage the flow of units, and then have a, somewhat critical care paramedic with them to then deliver those interventions. And let that spawn into something else possibly. But I think as things are progressing, as more and more things come to EMS, I'm thinking of drips, pumps, vents, 10 years ago, I think none of us would have ever considered putting a vent on a 911 ambulance. None of us were really thinking of whole blood 10 years ago. It didn't even cross my plate until 2019. And just as things progress, I think it's going to be the natural progression that states, systems, counties, jurisdictions are going to be creating critical care, APP type roles within their system. I think it has to happen, honestly.
Yeah. And to go off that, like we talked about with the medical directors, kind of going back, I watched an interview. It's on YouTube. It was an interview with an EMS fellow who used to be a paramedic, and I really liked it. It's on, like I said, it's on YouTube. His name is Kevin Argentieri, I think is how you say it. Great interview. One of the things that he talked about is his role as a medical director is to inspire and empower his paramedics working underneath him to function at, this is a direct quote from him, to function at their highest and best capability, which I thought is a very interesting, mindset as a medical director, but makes sense when you think about it. Like, these paramedics are functioning under you. Why would you not want to empower them to be better? And it's holding them to a standard, and they want to meet that standard, versus you are going to meet this standard because that's your job. Instead, the medical director says, I am going to inspire you because you want to meet that standard for you, not necessarily because it's a policy, because you want to meet that standard for your patients and for your job.
Yeah, it's profound, honestly, to hear that. But I think where that comes into play big time for me is, come find me in the field. Come talk to me, like at the station. Come run the calls. Like, be there to not only give me guidance overall, like bureaucratically and protocols and everything, but like show up. Like, that would make me be like, hey, I want to listen to you and I want to follow you. I don't know, Mike, what do you think?
I think the thing I was just thinking of is my litmus test that I have developed for a good medical director. Well, one of them is that when they do come out into the field, they come to the station, and when they do, they say, this is the best part of my job. Our medical director at my service, shout out to Dr. Simon, he says the most fun is when he comes out and he is on the medic unit with us. He said that's what he looks forward to when he gets up in the morning. Other medical directors, one of them told me that it took me going to graduate school for public health and then going to medical school, doing residency and a fellowship to realize that I want to be a firefighter paramedic when I grow up. He's like, that's the best part of my job, is doing EMS. So they come out there and they love it, because we all know that there are medical directors. If you have maybe some residents that come out and do ride-alongs, you can see they're just sitting there like twiddling their thumbs. They have no desire to be there. But there is a brand, not a brand, there is a species of ER physician out there who you can tell loves being out in the field and loves EMS. And those are the types of people that we need to harness and keep in this profession. Some of my friends rag on the EMS fellows, which I do get to some degree, because yes, I have had ones who come out and they're like, hey, yeah, I'm 27 years old. I have a medical degree. Here are all my opinions. and I'm going to do a ride along and play paramedic for the day. But I think EMS fellowships are a good thing, because if we can get these people who have invested all of this stuff into becoming an emergency medicine attending, they've done all this hard work, and then they want to specialize in what we do, I think that's a huge plus.
Yeah. So those people that want to be fellows in EMS, we need those people, like the people that really want to do it. And I probably sound like somewhat of a broken record some days on this, and I'm definitely an EMS nerd, so this should be no surprise. EMS needs these people. We need the spotlight of these people. We need their knowledge. We need their experience, and we need them to champion this field of medicine. Nowhere else in medicine, and I'll sit on this. I'll take this soapbox. I'll sit on this hill all day long. Sees as many critically ill people at the incipitous moment of their critical illness than EMS. Like, yeah, the ER gets our secondary, and the ICU gets that what the ER has kind of attempted to stabilize or has stabilized, but we are seeing them at the sickest point, where it's happening, where they live, what is possibly causing these issues, a whole host of things. And like, at times, EMS is still seen as the redheaded stepchild of medicine. And it's like, this is where it all starts. We are a lot of people's initiation to healthcare. Basically, I'm not even talking about the job. I'm talking about the people that we see and treat. And so like, we need docs to be like champion this realm of medicine, because without it, I think we can possibly like backward slide. So I don't know.
Yeah, I completely agree. It even not just the docs, but the nursing side of it too. Like, I got asked to come speak to my wife's nursing program. They have like an emergency nurses club, and these are all people who have no idea what EMS does. And I still get that from seasoned ER nurses. Like, I had one after I cardioverted a patient. They were like, "You guys can cardiovert on the ambulance?" I'm like, "Yeah." But
Yeah,
I think it's ultimately like it's an image thing.
Yeah, you can do that like probably like once a month. I don't know, Mike, do you experience that as well?
Yeah, but
I would not recommend saying no, but I've seen it done 1,000,000 times, because they will take you seriously and they will write you up. I know this from personal experience.
Yeah.
Mike, can you at least tell them I'm kidding? We can do this before you say that and walk out of the room.
But I think maybe it's corny, but I frequently tell people who ask what I do, I'm like, well, we do a lot of things. We are the nurse, the RT, the phlebotomist, spiritual care, registration, the tech. In some cases, obviously, we're very like surface level for all of these, but the pharmacist, the social worker, like the mental health clinician, all of these different things, and we have to put on all these different hats. And I think that's why I like EMS so much, because you go into a specialty, you go into ENT, it's like, oh, okay, how many ear infections, how many tubes am I going to see, how many yada yada yada. But emergency medicine, but specifically in EMS, like, I can go from treating a STEMI to taking care of a homeless person who's out of their meds and they're hypertensive and they just need to go get their meds. Like, it's monotonous sometimes, but you truly get a sense of society. And this is kind of going into more of like a philosophical standpoint, but you get a sense of society and where we are in society by how we treat like our most vulnerable populations. And I didn't realize that until I worked in an inner city in EMS, like a very well populated area with a large, like, impoverished but also health illiterate population.
Yeah, we definitely play a huge role. All right, we have been talking about this topic for 32 minutes now. Let's move on. What else do you guys have?
I honestly, I don't have anything on an agenda.
Okay, well, I'll do the one from last night, I guess. This guy asked, and I get this question all the time, I'm a new medic. How do I deal with the anxiety of being a new medic? and the stress.
Josh, you want to go first?
Yeah. I'm very blunt with our new medics, and I just tell them, I'm like, look, for the next 2 years, you're going to question a lot of what you do. You're going to run calls and have outcomes from these calls and decisions that you made that are not right, but not wrong at the same time. Sometimes they're wrong decisions and sometimes they're really good decisions, but you're going to constantly question yourself for the next 2 years. And I'll be blunt. You're going to shit your pants for 2 years, straight up. You're going to come to work. You're going to be scared. You're going to be anxious. You're going to wonder about what you're going to get. And then when you run the really weird call, you're going to question yourself for about 2-3 shifts. One of my old students, he is on B shift. I'm on C shift at my station. He's on the same station. And he's worked overtime with us a couple of times lately, and we've just broken apart calls. And he's like, well, but it presented this way, so I treated it. So I'm like, I get it, and you're not wrong. But let's talk about this. Let's break it apart, And it was a call that was a patient that probably had 2 or 3 other issues that were causing what was going on currently. And what they treated was not wrong, and they treated it appropriately. But there was other things that could have been looked at and taken into consideration. I'm like, hey, man, this is just, you're being new. You're learning. Take everything in, break everything apart, talk about calls, and just understand you'll get it. It just takes time. There's no way that we can give you all this experience, knowledge, and wisdom in the span of a 1,200-hour course that may be jammed into 6 months or over 2 years and expect that day one you're going to walk out and be as good as, we'll just say a 10-year medic. We'll just put a number on it. Malcolm Gladwell talks about his thing with like 10,000 hours it takes to master something. And a lot of people think, oh, is it like 10,000 calls in EMS? And I wouldn't say that necessarily. It's not a direct correlation, but it takes time. Like there's nothing that we do in life that day one after learning it, we're the rock star masters at it. We're going to stumble, we're going to fall, and we're just going to get up and we're going to learn it from it and keep driving. Just get through it. Just keep driving through it.
Yeah. I frequently, I've been a medic. I just passed my 3-year mark. So I'm of the newer, but I was in AEMT for 3 years in this system. So like a lot of experience, at least a lot of calls run. What I always tell people,
you were cosplaying as a paramedic.
Yes.
This medical director called me this week and he just goes, cosplaying as a paramedic. He's like, you were on fire this week.
Yeah.
Anyway,
we're not on the AEMT discussion. But I always tell people, find a mentor. Find a good mentor, like somebody who, it's not just like, oh, this person's been doing it for 10 years. Like we all know those people who are slugs and have been medics for 15 years. But find a good mentor. That doesn't mean they need to be in this for long. They could be the 3-year medic, but they are hungry and they're constantly learning and they're constantly trying to do the right thing. So find that person that you want to emulate and ask them questions, talk to them. Like I frequently get, everyone sends me their interesting EKGs. They're like, hey, what do you think about this? And I tell them, and they're like, I wasn't even thinking about that. And I send them like Life in the Fast Lane or whatever. But find somebody who you, like I said, you want to emulate, that has the behavior and the traits that you want to see as a medic. Be the person that's like, oh, I want to be that person. I want to be that medic that when, I open the back doors on an intercept, the person that's in this inside goes, thank God it's you and not somebody else. Because even if we have a shit show, we're going to figure it out because this medic is here. And so just find a mentor, find someone you want to emulate, and find someone that you can learn good habits from.
Yeah.
100%.
There it is.
I don't want to sound like the cranky old man here, but because people are going to go fucking nuts if they misinterpret what I'm saying. I am, as you all know, I'm very big on the mental health and the stigma being broken, all that, blah, blah, blah. That being said, I see a lot of people who want instant gratification. They want to instantly be comfortable in the profession. They want to instantly be accepted by their peers. And I see a lot of lack of resiliency. And this job is stressful, no doubt about it. And I do think that everything you guys said, 100% agree with. I think that we need to impart to people and be very upfront with them that this is going to suck. This is going to be very stressful, and it's going to take time. Like I have one person who DMs me all the time, and I've kind of tried to I've gotten less gentle about it as I continue to get messages that you need to practice some freaking resiliency. Like, and this sounds like a you problem, not an everyone else problem. But I don't know. What do you guys think?
So I kind of talked about this a while ago when we had oh my God, what's his name? The Viking therapist on. And we talked about how dynamics work in like a firehouse and public safety in general. The realm we work in is a super prove yourself, prove your worth realm. Like if you come in and you don't show up, you don't do the job well, you don't care about the job, you don't care about getting better personally and professionally, you are going to this job is going to eat you alive. There are people that seek out this environment that we work in because of what it is. They know it's a place where you have to be on top of your game all the time. What your life depends on it, the patient, the civilian, the citizen's life depends on it, whatever it is. And you just have to prove yourself every day. And it doesn't stop when you like hit some magic probationary end program period or anything like that. You got to prove yourself every day, essentially. I work on a shift of 16 people, and if I show up one day and I'm just a bag of ass, someone's going to call me out and be like, dude, what is wrong with you? You are not doing anything right. You're lazy, whatever it is, and you just got to prove your worth. Honestly, this is a job that eats its own all the time. And public safety in general does that. That's it. It's as you said, it's tough to say it without sounding like a dick, but you got to grow some like a thick skin to it. You can question yourself in your own mind, but on the exterior, you got to fucking put up. Honestly, you got to do the job. And if you show it, like for that new person that's probably DMing, I imagine they're new, like that's DMing you. Walk in and be like, hey, if it's an EMS only job, like, hey, I want to train on this. I want to come in and I want to talk about this. I want to have this discussion. Or let's watch this video. Just drop $150 and get foam frat and be like, hey, each shift we're going to sit down and watch a video and we're going to talk about the topic. I'm new, but I need this refresher just as much as you do, type thing. Or just, figure out what it is that proves your worth in your service and do it. As long as it's professional and, abides by all standards and morally correct. Okay. We're not advocating amoral activity.
Yeah. I 100% agree with that. And it kind of reminds me of kind of another topic I had was mental rehearsal. Like, do you guys ever mentally rehearse skills and calls in your head? Like to state, like maybe a skill you haven't done in a while or have never done.
Yes, all the time.
I do this all the time, and whether it's a crike, because I've never done a crike, I mentally rehearse that in multiple scenarios in my head, or intubations, or okay, if I have this sick pediatric with X disease process going on, what would I do? Because I think we all, at least we should, like go over our protocols often to kind of refresh ourselves. But I don't know if as many people mentally rehearse their role.
They don't.
It's not common.
And what made me think of this is you may have watched this too. It's a documentary. It's called The Blue Angels.
Yeah.
And it's on, that was probably one of the most profound things I've ever watched, because here is a group of some of the highest performing individuals in the world. Like, they have such surgical precision, and they have to, because they're, 3 feet away from each other in jets, and one wrong move and they're all done. They do something, and you may have seen this in the social media world. They do rehearsal before every show, and they all sit in a room around a table. They close their eyes, and they all do all the motions of, putting up on the accelerator, backing off on the accelerator, using the stick. And you have the boss who is sitting there with a cadence, and they all just run through their entire routine, essentially. And that way, by the time they actually get to the show, it's second nature to them. They're like, I have rehearsed this 15 times or even more, and I know exactly what I am supposed to do, and I know exactly what this person is supposed to do. And I say that to people a lot when you're running a code, for instance, and we have more resources than God in our system. But when codes really run efficiently, it's when everybody knows their job to a T. And if I'm the code commander, I don't have to like look over my shoulder or look at you
That
and be
is
like,
a great name, Code Commander.
We use CPR boss.
Yeah. We do like the pit crew, so we do position 1. That's essentially the code commander. But like, I don't have to watch and make sure that you're managing the airway correctly, or that you are, the person on drugs is pulling up the right drugs. I should know that you know your job to a T, and I shouldn't have to worry about that, because that way I can focus 100% on my job.
Yeah, I do that all the time. It doesn't matter if it's a medical call or fire call. Like, if we're going to something, and whether it's they say working fire or not, I'm still thinking, okay, we're gonna pull up. I asked the officer, hey, we're gonna be on driver's side or officer side? Driver's side. Okay, cool. So that means I'm pulling the line. This is how I'm gonna do it. I'm gonna make sure I'm making this way to the door. Da da da. I'm flaking out. Da da da. Even something so simple and like physically not crazy, I'm thinking about it the whole way there. When it comes to a medical call, like on codes, if I know I'm going to be the first medic, I'm like, okay, cool. I'm going to be on meds. I know I'm going to be doing an IO. This is how I'm going to do it. This is where I'm going to sit. This is where I'm going to be on the patient. Okay, I'm the second medic. I'm probably doing airway. Okay, cool. So in my mind, I'm going to get everything ready. I'm going to be doing suction. Okay, if the airway looks like this is how I'm going to present. This is what I'm going to do. Da, 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 da. That's before I even walk in the door.
The other day, you're hand heavy on the way to the call.
Yeah, yep, hand heavy. You've got to love it. And then the other day, where Mike was talking to me about something, and I was going into trouble with breathing as a second medic, and I was like, if I have to cut this guy's neck, I'm blaming you, Mike. But on the way there, I was thinking, because it was dispatch trouble breathing, and they're asking for a second medic. I was like, okay, what am I going to do? Okay, this is the process I'm going to do. This is what I'm going to have to do. Laryngeal handshake, da 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 da, cut, pass tube, blah 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 blah. But just things that you have to mentally prepare for on the way to the call. It just makes sure that, like, when you step off that engine, that chase car, that medic unit, you're ready to go.
Yeah, it's kind of like the like, you don't rise to the occasion, you fall to the level of your training. And I think that kind of goes back to that exact phrase.
We talk a lot about that in the episode I recorded with Haney about the surgical airway debrief, about resorting to the level of your training and how you go on autopilot.
Yeah, 100%. It's like,
it really is. Go ahead.
When you get into like that zone 4, zone 5 heart rate, and you lose all gross motor like abilities, you fall back to what is going to keep you alive in the moment. And in medical calls, it's what did you learn in medic class? I think it was Levitan. Was it Levitan? Someone talked about it at Fast 25, how, like, when it comes down to it, all you're going to resort to is what you learned on basically like day one. We're going to say day one of whatever it was. And hopefully that education was pretty good then, and you can fall back on it. but also preparing yourself makes it so that maybe you don't fall that far back. You only fall back to when you initiated the thought of all this. So,
yeah, I had this discussion with one of my partners the other day because they were pretty new, and we were talking about what do you do if you are stumped, like if you're on a complex call and you don't know what to do next. What I told them is what I always do is I feel the patient's radial pulse if they have one, but I get down on a knee or wherever I'm sitting, I feel their pulse and I look at the monitor, because if I feel their pulse, I'm like, okay, they have a pulse, or maybe they don't, and now I know what to do. But if they have a pulse, all right, we're good. And then I look at the monitor and I say, okay, where am I at right now? And when everything else is going bad, if you just kind of go back to that basics of, okay, I have a pulse, I'm breathing, patient's breathing, patient has a pulse. And if they don't, we'll fix that. But just kind of back to basics, if you will, if you're kind of lost in the sauce, and just be like, all right, where am I at? What can I do right now that can make a difference? Okay, I can push this med. Got it. All right. I can put an OPA in. Got it. Let's do that. It's you talk, Mike, about analysis paralysis a lot, and it's kind of the same line of like, don't sit there and get too far down the weeds and then miss some critical intervention, and you're like, oh crap, I haven't been doing that. The patient's not breathing, and they haven't been breathing for 5 minutes now.
Yeah, for sure. Back to basics. BLS before ALS.
what other listener questions
Josh.
you got, Mike? Yeah.
Do you have, or Jake, what else? You said you had a couple things, Jake.
Yeah, I had one more thing that I really wanted to talk about. Do you guys carry Pitocin at either of your services?
I do not.
Yeah, but all OB calls should be BLS anyway, so fuck it.
Okay,
well, this is why I wanted to bring it up.
Women have been having babies. Women have been having babies for 1,000,000 years.
Move on. Next topic.
Even though the U.S. has one of the worst maternal mortality rates in the developed world, but I'm sorry, my wife wants to be an L&D nurse, and we have very passionate discussions about maternal mortality in this house. But yeah, Pitocin is one of those things that we started carrying, and that's one thing we may use once or twice a year. Not even, we use more than that, but our protocol is to give it every field delivery as long as the patient gives you consent. Yeah, so we just give it prophylactically every single delivery. And the argument for that was, this is the maternal mortality rate in the US, and this is the amount of those are due to postpartum hemorrhage. The cost benefit of giving them 10 units of intramuscular Pitocin versus, and potentially preventing a postpartum hemorrhage, versus, oh, they're hemorrhaging and now I'm going to give them the Pitocin, is kind of our system's thought on that. And
I'm a medical director and I'm not getting fucking sued for postpartum hemorrhage, so everybody gets Pitocin. That's me being negative.
I mean, yeah, it's definitely, I haven't given it yet.
Like,
and that's the thing, like going back to the medical director standpoint, yeah, it may be that liability thing, but I mean, I think to me, it's one of those cost benefit things. Like, is Pitocin, like 10 units of intramuscular Pitocin, going to cause harm? No. It's usually, from my understanding, when we see Pitocin cause harm, it's when they've been inducing labor with Pitocin for 5 hours and now the uterus is like tired, and then they have a postpartum hemorrhage. And we're not talking about it for induction of labor. Like, we're not doing that. But, giving it prophylactically to prevent a postpartum hemorrhage, I think is probably a good idea. I mean, I'm not an OB, but
I have absolutely no idea, to be honest with you. This is one of those, I don't think there's good guidance on it. I had a side of the road delivery a few months ago, and she was bleeding a little bit, and I was looking at her, I was like, they say a little bleeding's normal. I'm like, I don't know if this is normal or not. Like, she looks fine. She's not shocky. I ended up not giving her Pitocin, and she did fine. So I just don't think there's good guidance on it. It would be interesting to ask an OB, do we wait until they're in shock to give it? Because we know that pregnant women, and I'm sorry, if you had a baby 2 minutes ago, you're still physiologically pregnant. So do we wait for that woman that we know can have delayed signs and symptoms of shock to exhibit those delayed signs and symptoms because she's already decompensated at that point? Or is giving Pitocin to everybody swinging the pendulum too far? I truly don't know the answer.
You can bleed a lot into the uterus and behind the uterus too.
It's never happened to me, so I don't know.
One of my favorite podcasts is the Critical Care OB podcast. I highly recommend anyone who is unsure about. Yeah, it's clinical concepts in obstetrics. They have a whole critical care OB course that you can take, which my wife and I paid for. Which, if you're unsure at all about OB calls, which I know a lot of medics are, I highly recommend that podcast because it is a maternal fetal medicine doc and a couple L&D nurses. And they talk about it from the in-hospital standpoint, but they really harp on things like vital signs and don't ignore the female, like the pregnant patient who says, I can't breathe. Things like that. Like, don't just say, oh, it's fine, it's anxiety. Like, there are things that they talk about in that podcast that are really, they sound intuitive, but you're like, oh, I've never thought about it from that perspective before. So highly recommend.
What do you guys do, Josh? You don't have do you have any specific OB protocols other than the regular old eclampsia John that the rest of the world is doing?
No, I mean, we factor in TXA and blood, obviously, now. I mean, our protocols for preeclampsia and eclampsia just recently changed. And now we're prophylactically treating preeclampsia. If our lower threshold is 140, so anywhere between 140 and 159 on 2 repeat blood pressures 15 minutes apart on a pregnant patient and or someone that is up to 6 weeks postpartum is going to get MAG. So they're going to get 2 grams MAG right off the bat. Go to,
as you should.
Anyone over 160 is also getting lobetalol.
Yeah.
So that is a change from last year and all the years prior where we were only treating eclampsia. And that was with MAG. So now we're prophylactically, but we're getting ahead of the curve before it's an issue. And trying to keep it from
In Pennsylvania, we still wait till you develop cerebral edema to treat any symptoms of preeclampsia. So you have to be seizing for us to give the MAG.
Yeah, my protocols are similar to Josh's, where we can give it for preeclampsia. Which if there are any MFMs or OBs out there that disagree with me, please, I want to know, and I want you to change my mind on it. But for me, MAG is kind of it's a cost benefit analysis. And to me, there is way too much potential benefit of MAG and pretty low side effect profile of MAG, where I just give it. If I think that they are preeclamptic, I just give 2 grams of MAG along with, if they have a severe headache, you can give them like a migraine cocktail in a way. You can give them whatever your protocols say, but Tylenol, Zofran, Reglan, whatever you're allowed to give, because my wife had preeclampsia twice. And so this is kind of a very personal thing for me. I watched them give her like a migraine cocktail and fluids, and they're like, well, none of this is working. You still have this headache and you are blurry out of one of your eyes and your pressure's high. All right, well, we have our diagnosis at this point with labs and stuff, but I feel like it's kind of MAG has a really good side effect profile. And if I can potentially avoid you seizing at all, I'm going to take that. I'm going to take that chance that I'm going to give you 2 grams of MAG. And yeah, you may feel a little bit flushed and hot, but you are less likely to have a seizure. And that's a win-win for mom, the baby, me, everyone.
100%. I really like that we're being proactive on these type of calls now instead of reactive. It's ties back to what we were talking about earlier. We're bringing this care to the patient side and trying to actually change things.
Yeah. 100%.
Mike, you have any other?
That's all I have, Mike.
You have any other listener questions that you really want to pose to us, or and we're coming
I've
up
got
on your
all
usual
kinds
time
of
frame.
things I could talk about, but I mean, if you guys like, I don't have anywhere to be. We can do another topic or question if you want. Yeah, I mean, if you guys want to bring something else up, by all means.
I've been trying to rack my brain since you asked about random ramblings about things I really wanted to talk about.
Oh, I have one. I just thought about.
Bring it, and we'll end.
I'm
with,
full.
We'll end
I'm
with
full
this.
of. I'm full of stuff.
Yeah.
I was riding with a trainee recently, and him and I were in the front, and the FTO's in the back, and so I'm able to chat with him, and we had a really good discussion about education. One of the things that him and I talked about was he was frustrated that some FTOs don't teach to his learning style, and they're like, "This is how you're going to do it." And I'm a preceptor, I'm not an FTO, but my personal philosophy on teaching is it is much easier for me to change my teaching style than it is for the student to change their learning style, because you're the one learning, and it is much harder to learn something than it is to teach something, in my mind at least. So, like, if
I think it's incumbent upon both parties, because my first thought is, if I had a student who said, "Oh, you're not teaching to my learning style," my foot would be inserted so far up into their ass that they would need a surgeon to remove it.
I agree.
Now I'm going to do a reel where he stitches that in and says that I'm mean.
So I think it's. I wouldn't go so far as to what Mike says, but at the same time, there is a measure of that. I think it's a two-way discussion. It's not like, hey, you need to come to me on this. There is some modification needed for the learning aspect. Like, it's kind of like a resiliency almost thing, that not everyone's going to cater to you and how you do things. Like, I guarantee when they went through paramedic school, not everything was the same way as their learning style. You know, when I teach, I try and incorporate all learning styles. I have a little bit of visual. I'm obviously speaking. I have some written stuff. If I can give a handout, I give a handout, you know, stuff like that. But it's definitely, each student and teacher interaction, and I'm just going to say teacher for preceptor, FTO, whatever you want to call that term, is going to be different. And I think it is incumbent on FTOs to understand, like, hey, sometimes you have to modify some things, but you don't have to completely change things, because also it's important to understand that there usually, grain of salt here, usually the people that are FTOs know how to relay information, knowledge, skills, abilities, experience into good teachable moments. They should be able to. It should be part of the program. Obviously, that doesn't always happen. But part of that is understanding how to form something that their student can receive. So, like, you know, you don't have to be completely rigid on your teaching style, but the student also needs to understand that, like, hey, they can't be completely rigid on their learning style. It takes work. If they're a new FTO, it's probably not going to work out easily. It's going to take time, because you have to have this experience with different students to see how to do things. Same thing as the student learning new things as well. What do you think about that, Mike?
I hear what Josh or Jake thinks.
No, I actually agree with both of you. I think there is a little bit of give and take. I do think, because I'm a very visual learner, I'm a very hands-on learner. I don't do well sitting down in front of a book and just reading a textbook. So, and even in paramedic school, my paramedic instructor may get mad at me, but when all my classmates were like rereading the textbook, I was on foam frat, and I was watching foam frat videos, because that, to me, that's how I like absorbed all the information. And I think it's hard, because you want to give the student the tools to learn, right? I think that's part of being an educator, is giving the student the tools to figure it out for themselves. But also, yeah, it's a give and take, I think, in a lot of ways. So I agree with both of you and what you're saying. For me, that's just like my teaching style is like, oh, let me change the way I'm explaining this to you. Let me try to change it in a way that you can more easily understand, and let's break it down into simple terms and then build up from there. Because my personal belief is if you can't explain something in the simplest terms, you don't understand the topic yourself.
Yeah.
Would you guys agree with that?
100%. And there have certainly been times as an educator where I'm looking at the person and they're just giving me this blank stare. And I'm like, I know this is not a stupid person that I'm dealing with. There's got to be a way that I can explain this better or lead them down the path so that they discover the knowledge and that they understand it. So I don't want to sound too rigid and be like, oh, fuck them. You know, if they don't get the knowledge after I explain it, you know, that's their problem. No, I'm not like that at all. It's very stressful having a struggling student. You do feel a duty to them. And I mean, I've been like, how can I explain this to this person? How can I get them through this? You know, what can I change up? You do have to do that. It's part of being a professional educator. But there, man, I'm telling you, I totally could see some student being like, they're not teaching to my learning style. Good luck applying to our department once you're done.
Mike, you said it right there at the end that like it's incumbent on us as educators and teachers, FTOs, whatever, to kind of recognize when the student isn't getting it and be like, okay, how do I tailor this? And like, hopefully, whoever this person is and their FTO, the FTO is doing that. And if it's like getting to the point where everything's just not getting through or it's just not working somehow, I think that's that time when hopefully the FTO recognizes it earlier than the student is going to say something. The FTO goes, hey, let's have a sit down. Where is the disconnect? I am teaching you this way. It is not relaying somehow. What is not working for you? And what is not working for me as the instructor? Where do we go from here? And sometimes actually it can result in I think you need a different FTO. And it's better to find that out early. Yes. Way better to find that out early.
Yes. There's also a boundary that I have established in the last few years. It's that I am no longer, as an FTO, it is not my job to reteach you paramedic school. Yeah, I'm going to have to tutor you on stuff. That is fine. If you don't understand 12 leads, I'm happy to sit down with you. I'm happy to go over pharmacology, help you review. That's what I'm here for. But it is no longer, when I have one of these students who is a know-nothing, I kick them back to the school. I'm very upfront with the school. I've been kind of scathing sometimes before dealing with the student and the instructors. It's like, how have they gotten to the point where they're in their field internship? They tell me they've gotten A's on all their exams. And here is a specific list of things that they had no clue about. You know, this is not my job. This person is not ready to be in the field. Go handle this.
Well, like they can't
mix
mix
back to the school.
They can't mix a norepi drip. And I'm like, you're in capstone and you don't know how to mix a drip, or they don't know that norepi is a pressor or something. Yeah,
that would be
that too.
Yeah, if someone came to the field like that, that's going to be a hard time. And I'll be honest, there are some.
Yeah, there's one school in our area that was giving us a lot of students like that.
There's students that you're going to get that there's just nothing's going to work with them, unfortunately. Like some people, like we had this one student, I don't know, probably 2 years ago that just nothing was getting through. We could not get this guy to engage properly and do things.
They're
and
not teachable.
Be proactive. Yeah, and even our
battalion chief,
our clinical coordination guy was like, I know you guys are doing everything possible. Like I know there's nothing you can do. This is his second attempt at this, and the results we can talk about later. But like it's just there's some that just can't be taught, and it is how it is. So luckily, I've had a good streak of.
And I think that's lately. I think that's when you, like Mike said earlier, like you have to be blunt with them. I think you mentioned that, Josh, too. Like you have to be blunt with them at some point. You're like, all right, we tried all these things. Like, I don't know how to help you. So at this point, like, I don't know if you're cut out for the job. And I think, was it Cody that said you gotta like
chew ass?
Chew ass, yeah. I loved that term then, but
the internet did not.
Yeah, I know.
Well, one side of the internet did it.
but
The other
it's-
side did it. It was split between TikTok and Instagram. But
which we know your feelings on TikTok, Mike. But yeah, I think at some point you got to realize like we're not getting anywhere, and we just need to call it and say, I know you've invested all this time and money and everything, but maybe you should consider a different career.
Love it. But when I will say the caveat that if you're going to be blunt, you must also be specific
and document.
Yes.
and document. All right. I think this is a good place to stop.
Yeah.
This has been lovely. Thank you, gentlemen. I have to go cut and marinate chicken now.
Have fun with that.
Yeah. Well,
This
Josh
has
and
been
Jake,
great.
thank
Yeah.
you guys. I'm going to hit stop.